Hi.
Hello.
Hi, good evening.
You okay?
Yeah, good, thank you. Yourself, you all right?
Yeah, not bad.
Good.
I've got a little bit of, I've been in a swimming pool, so my eyes are a little bit leaky, sorry.
It's the right weather to be in a swimming pool, though.
Yeah.
It's been so warm. It's nice that we finally managed to collaborate together, though, which is great.
Yay! I wasn't very well last time. I really wasn't very well.
Oh, it's so hard, isn't it? Especially in the current situation.
Yes. Well, it looks like we've got a lot of viewers now.
We have, yeah. So should we crack on?
Yes. Yeah, where do you want to start?
Good. So I guess it's useful to explain to mums what perineal trauma is before we start. So the perineum is essentially the area between the vaginal opening and your back passage, and that's the area that is kind of most susceptible really to some trauma following childbirth. And I think it's great that we're chatting about the subject tonight because it seems to be a little bit of a taboo subject and mums don't talk about it. So if midwives aren't talking about it either, then we've kind of got no hope, have we, of demystifying it.
And I think as well, a lot of people don't even realise what that area is or does, or when you speak to women and you talk to them about the perineum and they're like, not even realising exactly what can happen during birth.
Yeah.
So I think this is going to be quite informative. Yeah,
I totally agree. And it's really important that we understand our bodies and what's happening during the birthing process. So hopefully now everyone can pinpoint whereabouts the perineum is on their body. And then I think the next sometimes reassuring things for mum to know is that actually around 85% of women who have a vaginal birth will sustain some extent of perineal trauma. Because I think when a woman has a perineal tear, because it's not something their friends talk about, they talk about how they're feeding their baby and what their first outfit's going to be and their pushchair, but they don't talk about perineal damage. So they kind of feel like, oh my goodness, it's only happened to me, this hasn't happened to anybody else or anyone else in my friendship group. But actually, if 85% of women do sustain trauma, then the chances are it has.
Yeah, or I think they kind of gloss over it a little bit, like, I had some stitches, and you don't talk about where those stitches are or how it's happened or how it's healing. And I think women kind of, I don't know if it's a little bit of embarrassment or just the sort of lack of understanding how many women experience the same thing.
Yeah, and I think that the more we can discuss it and the more we can kind of normalise it, we realise that it's a little bit of a tricky thing to discuss, but the more we can talk about it, then hopefully the more comfortable women will feel in kind of dealing with it afterwards, I suppose. Yeah,
totally.
So we've kind of looked at the perineum, but it is important to recognise that actually trauma can happen to other areas. So sometimes the labia, sometimes there's clitoral or urethral tears, and then sometimes it does affect the anal sphincter. But I think we should probably, I don't know about you, but maybe classify the tears because it might be terminology that women hear about, but they can't quite put together what that actually means in terms of their body.
Definitely. And I think sometimes when you say to somebody that they have this, it sounds, to us, it's normal, but I think to women that can sound like, that sounds so serious. So I think definitely explaining the different classifications is a big help.
Yeah, so we generally classify it in 4 different types, broadly. So first degree tears are kind of the lesser of the trauma, and that's where there's like a small tear that generally just affects the skin, and if it's not bleeding and it's nicely aligned, then it doesn't necessarily need to be sutured. On an individual basis, sometimes a couple of stitches will just give a slightly more cosmetic result, or if there's a little bit of bleeding, then we'd recommend just suturing those vessels, but generally they don't need to be. And then the kind of next degree is the second degree tears, and these are probably the most common. These affect the muscle layer as well, and sometimes the vaginal wall, and we would generally recommend suturing of all second degree tears. I'm sure you kind of practice the same.
Yeah, I mean, again, individual basis. I think that you can have small second degree tears that maybe are very, very neat, that aren't bleeding. Sometimes I think sometimes, rare instances, you can actually maybe cause a little bit more damage by suturing some of the smaller second degree tears than actually just leaving well alone. So it is very case by case. And I think it comes with experience, doesn't it, as to knowing what the best thing to do is. Yeah. But yes, there are instances where you don't need to suture a second degree tear, but by and large, generally, a second degree will need suturing.
Yeah, absolutely. And then the other thing that ladies might have heard of is an episiotomy, and that's where we do a deliberate incision to the perineum. And this kind of involves the same structures generally as a second degree tear, so it would be repaired in the same way. The difference is, as we say, it's done deliberately. And around, I think the statistics are about 1 in 7 women in the UK will have an episiotomy to facilitate their birth. It's really important that we realise that they're no longer performed routinely, because I know back in the kind of 80s and 90s, if it was your first baby, that was it, you were getting an episiotomy.
Yes.
Whereas now they're absolutely not kind of standard practice.
No, it is, like you say, a case by case, and it's usually performed at a time if instrumental deliveries are about to happen, and it's usually so that, you know, apparatus can be inserted into the vaginal tract to make more room, and, you know, if delivery needs to be imminent and quick, you don't have that time to allow the perineum to stretch. So we often do it to save causing trauma to any other area.
Yeah, absolutely. And I guess the other indication is if we are concerned about your baby, and we know your baby's going to come vaginally without the assistance of instruments, but that process just needs to happen a little bit quicker, and it does just provide that little bit of extra space just for your baby to be born just a little bit sooner. But it very much is for a medical reason, to prevent further trauma or to speed up the birth of your baby. It's not routine. Thankfully, which is good.
Yes.
And the other thing that I think is worth pointing out is that we do an episiotomy on an angle, because quite often, I don't know if you found the same, I have ladies that have had an episiotomy that are quite concerned that they're very, very sore on one side in particular, and they're concerned that that's a sign of infection, but it's just because that's where the trauma is.
Yes, I think even if you remember back to before your training, I think maybe even you imagine it to be a straight line downwards. Yeah. Because you think that it's on the perineum. And yes, it is on the perineum, but it's to one side. Yeah. So that you don't actually cause any trauma anywhere near the back passage. So, yeah, I think in your mind's eye, you just believe it to be a straight down cut, and it's not. It's actually off to an angle on one side. Yeah, so I think that's sometimes quite useful for women to know. And so we do it on that side, partially, like you say, to stop any damage to the anal sphincter, but also we've got these Bartholian glands on either, kind of just slightly above, and what we don't want to be doing is cutting through those, because they're responsible for sort of normal vaginal secretion. So if we're cutting through those, we're causing damage. So there is good reason why it's being done at an angle. It's not wonky scissors or anything like that. And then I suppose the more kind of extensive perineal traumas, which is where we get our obstetric colleagues involved. So your first, your second degrees, your episiotomies will usually be sutured by a midwife that's trained to do so. But when we start to look at third and fourth degree tears, that's when we want definitely our obstetric colleagues involved. And it's generally about 2.9% of women that will sustain these degrees of trauma. And this is where it involves the anal sphincter. So third degree tears can be categorised into A, B and C, and what that generally means is how far through the sphincter that the damage is involving, and then fourth degrees is where it goes through the epithelium as well. And there are risks involved with these in the future for women, so it's really important. We'd really encourage all women to have these repaired properly. Yes. And so that means not only having someone who's trained to repair these types of trauma, but generally also done in theatres with good analgesia and good lighting as well. Yeah, and I think that's something that people maybe aren't aware of as well is, you know, with the first and second degree tears that need suturing, we give a local anaesthetic so that we can repair them quite easily in the room or at home with a nice local numbing agent. But the more complex tears do need to be done under a good analgesia in order to get a very good repair. And to do that, because they are deeper, it is a good idea to have a good analgesia in place, which is usually under a regional, so it's under a spinal or an epidural that those are done, and it's, I think, important that women understand that, because that can be quite, I think that's quite a big fear that women have is having, you know, adequate pain relief to have, you know, sutures done, no matter what they are.
Yeah. And actually, it's really important that women aren't traumatised by their suturing experience.
Absolutely.
So if they've got a second-degree tear that they can't tolerate it being sutured in the room with local anaesthetic, then it's absolutely fine to stop and go to theatre and have proper anaesthesia. Because it seems to be, I think, relatively common, actually, that women find the suturing experience sometimes more of a trauma than their birth. And it really shouldn't be.
No, it really shouldn't be. And, you know, I think we should be almost telling women, you know, you have every right to say, you know, I'm really not comfortable with this. Please, can I have something extra, or can we stop, and can you explain something, you know? And sometimes just even the explanation of what is being done and how long it might take is just enough reassurance. But if you're ever unhappy, just speak to your midwife, speak out, use your voice. Don't ever be afraid. No. And don't just sit there suffering in silence, please.
Yeah, I totally echo that. It's really important that it's a kind of two-way thing, and that the woman's comfortable in what's happening, for sure. And then I suppose third and fourth degree tears, so there is an increased risk of incontinence issues and involuntary passing of flatus or faeces. And so that's part of the reason why we really want to get that repair kind of spot on. But the evidence at the moment is that 12 months down the line, about 60 to 80% of women are asymptomatic. But again, it's really important we get it right. And I just seen that Amy Ash said that she had a 3B tear, and she felt like she was being stitched forever. And I guess that's not an uncommon feeling, because you're kind of waiting for it to be over. It does generally feel like half an hour feels like 3 days, doesn't it?
Yes.
At that point. Yeah.
It's important to note as well that people who've sustained third or fourth degree tears, it's not just a case of being sutured and then merrily off on your way.
No.
There should be follow-ups. You know, you should be offered, you know, physiotherapy and, you know, and a follow-up 6 weeks later, because they are, complicated. Yes, I suppose that is the right word, isn't it? They are complicated, and, you know, you do need a little bit more extra support in those cases.
Yeah, absolutely. And then it's making sure that you haven't got symptoms that we need to be rectifying. So I would say if you are a lady who was sustaining a third or fourth degree tear and you're having some of these incontinence issues, then it's really important, again, that you speak up, because there is things that can be done. It's not all that's it forever. And don't wait until you've had all your children, because that's something I hear quite often. Oh, I'll just wait till I've had another baby. So you're living with incontinence for like 2 years in between, and we don't need that. No,
absolutely not. Absolutely not.
Amisha
and
just
said...
Yeah,
go on.
I was just saying, Amisha just said that she was given physio after, which is really important. Physios are really important with all perineal trauma, really, for the recovery process.
Yeah, definitely. Absolutely. There's someone saying they had a second degree tear with their first. Pregnant again, does it mean that you'll tear again? I mean, not necessarily. There will be scar tissue. So it is a slightly weakened area. However, pelvic floor exercises are imperative to, sustaining your pregnancy and having a good labour experience and strengthening those muscles ready for delivery again. Pelvic floor exercises. There is a video that's actually on my grid, on my IGTV. I've done a pelvic floor video, which you can watch, and that will absolutely stand you in good stead. But also remember that I think we'll talk about it in a minute. But there's techniques that you can use during birth that will help reduce the risk, let's say. Yeah, definitely. And generally, it seems to be that the higher risk of perineal trauma is actually in first-time mums, so about 9 in 10, and then that kind of drops down to 85% for the general population. So with second-time mums, generally your risk is slightly less, but it is a risk for anyone who's going through childbirth because of how our body's stretching.
So I guess that moves us on really nicely, actually, to discussing perineal massage.
Yes.
So there are kind of two ways, I suppose. There's the manual way, which I think probably we should talk about first, which is just inserting your fingers. And then there are some fancy little machines that are on the market as well. And so perineal massage is essentially using your fingers to try and just gently stretch that area of your perineum to try and reduce your risk of perineal trauma. Now, the evidence is a little bit hit and miss, but there was a really good Cochrane review which looked at 4 trials, which was almost 2,500 women, so relatively decent size, and it showed that perineal massage once or twice a week for about 3 to 4 minutes from 34 to 35 weeks may reduce your risk of perineal trauma and kind of ongoing perineal pain as well. And it was mainly episiotomies that it tended to reduce.
Yes.
The impact tended to be better for first-time mums and those who hadn't given birth before. But I guess it's worth a go. There's no harm. It gets you to know your body.
Absolutely. And I feel like as well, I think if you partake in perineal massage, it also helps you to be in tune with your body a little bit more and understanding your body. And, you know, I feel like we don't discuss perineal massage enough.
No.
I feel like, again, that's another kind of taboo subject that people just don't understand.
Yeah.
And and the way that I often explain is I tell people that if you imagine that this bit of tissue the bit of skin between your thumb and your finger is a bit like your perineum, and you can almost practice on that bit of skin before you can identify where that perineal skin is underneath.
Yeah, and I suppose as well it's a bit of a taboo subject because it involves touching yourself, and and actually when you're giving birth, you are going to be to some extent a little bit exposed. So the more comfortable we get with our own bodies, hopefully the more comfortable it'll be in that. So Eleanor is pregnant with her 3rd and she's never heard of massaging. So we absolutely need to explain how to do it, I suppose.
Yes,
We've got to.
Absolutely.
So what you want to make sure is you've got clean hands. You're in a nice comfy position, and a mirror's quite handy as well, so you can kind of see what you're doing, especially if you're heavily pregnant in your 3rd trimester with a decent sized bump. And you want to put your thumbs sort of 2.5 to 4 centimetres just inside the kind of back wall of your vagina. And then the idea is you kind of press downwards and forwards towards your anus and to the sides. And you feel a little bit of a burning and a stretching feeling, but it shouldn't be painful. And you want to kind of hold that stretch for kind of 1 to 2 minutes and then just gently massage the kind of lower bit of your vagina for kind of 2 to 3 minutes and focus on that feeling of relaxing, so relaxing your perineum, because you need it all to be relaxed to facilitate the birth of your baby when the time comes. And it's kind of a U-shaped movement, so you're kind of going upwards and outwards in kind of like a U-shaped movement. And it's a great time as well to kind of think about your breathing exercises for labour and birth. You can kind of facilitate that into it as well, kind of your deep breathing, to try and sort of get used to how it's going to be, I suppose, when you get to the crowning phase.
Multitasking.
Yeah. We're time poor, so we've got to get both things at once.
Absolutely. Someone's just said that they tore with their last 2 big babies, £8.14 and £10.2. It would be handy to know to try avoiding it. Are there different positions in labour that you can do to prevent tearing?
Oh, interesting.
Yeah. So I feel like I bang on about active labours quite a lot, but they are just so important. Being in an upright position, taking pressure off the coccyx and off the back passage so that your body has a chance to stretch and move and baby has a chance to get in a good position. And being in an upright position just means that gravity is on your side. So you can actually birth baby's head nice and slowly because you've got gravity on your side. So you have less work to do, which is always a bonus.
Yeah.
And it just means that when you birth baby's head nice and slowly, you're giving all of that skin and muscle chance to stretch. So I would definitely say get off the bed if you can, get off your back if you can, and just try different upright positions, squatting, crouching, on all fours, on a birth stool, squatting in a pool. Any of these positions are just ideal for helping to try and reduce that trauma and just get gravity on your side.
Yeah, totally agree. And it makes sense when you think about the mechanism of birth. It makes perfect sense that you would be adopting one of those nice upright positions. And I think most women in labour tend to move into a position that just feels natural for them, and it tends to be in something that is quite upright. And I guess the only exception to that is ladies with the dense epidural, because you haven't got the same mobility. But what I would say is most beds in a labour ward room now will go into a beautiful kind of upright chair position.
Throne position.
Yeah, literally,
so
you are like a throne. And you can have your feet slightly raised, and that's brilliant for gravity, because it's literally like being sat on the toilet with a backrest.
Yes.
So,
or if that's not possible, if the bed doesn't have that kind of movement, then laying on the left side, on the left lateral, with one leg supported up, if your birth partner can help support your right leg so that it's up in an upright position, so you've kind of got it right angled to your body, then that's a brilliant position. If you can't do sort of sitting up, then that's a nice position for an epidural. Yeah,
it's a great position. And I've seen those peanut-shaped balls.
They're
brilliant for, again, that nice comfy position. But you could do the same thing with pillows and towels. We can be inventive depending on what we've got, but it's just having that support, isn't it?
There's no one more inventive than a midwife with a labouring woman.
Yeah, that's so true. We're totally on your side. And then we've just had a question that I just saw. How often to perform perineal massage? So 3 to 4 minutes, once to twice a week, from 34 to 35 weeks seems to be where it's most effective.
Yeah.
So I think the lady was 36 weeks, so start tonight. Why not?
Brilliant, absolutely. And there are sort of fancy oils that you can buy, but anything that's kind of sort of a natural lubricant, things like a coconut oil that's not too greasy, not too oily. Something like like olive oil is really quite greasy, but something like a coconut oil, which is nicely absorbed and it's quite natural, should be a good substitute if you don't want to spend money on special oils and stuff. Yeah, it just needs to be lubricating, doesn't it, really? So it's not uncomfortable. Yeah. So you don't need tons of it. Yeah, no, you don't. And the other thing that's quite interesting, I think, is the use of warm compresses for birth. And that's where, as midwives, we can be really helping to facilitate, hopefully, a reduction in perineal trauma for women. So, again, there was another Cochrane review. There was almost 15,000 women, actually. And it kind of looked that fewer women with the warm compresses in the kind of stages of birth had less 3rd and 4th degree tears. It didn't seem to reduce the kind of lesser degrees, but certainly the 3rd and 4th. And again, it's something that's so easy. So it's to have a conversation with your midwife. All it needs to be is a warm maternity pad or some gauze under warm water. Yeah. And as your baby's even a flannel.
Yeah,
even a flannel.
Great. And it's just providing that little bit of compress as your baby's birthing. And actually, women tend to find it quite soothing as well, I find.
Exactly, yes. Yeah, definitely.
So again, it's something that there's no harm, but if it helps, great.
Yeah, and I think as well, we all sort of mention that ring of fire, but you've never known anything like it until you experience that actual burning sensation of your baby's head passing through. But a warm compress can actually even reduce that stinging sensation that you can feel when baby's head is crowning.
Yeah, absolutely. And we've got lots of other questions. I've been told several times to only push through a contraction and pant or stop when the contraction finishes. Can this prevent tearing? I think this might be a little miscommunication. So when you're in labour and you're having contractions and you're at this pushing stage, we do only want you to be pushing when you have a contraction, and that's what your body will be telling you to do, because the idea is as you have a contraction, that kind of does some of the work for you. The contraction pushes your baby down and then you push as well to facilitate that process. The panting bit is really important, actually, and that's as your baby's head's crowning. And the kind of purpose of that, I often say to ladies, imagine you're blowing out candles. And the idea is that the baby's head comes a bit slower so that the perineal area gently stretches rather than just suddenly opening to birth the head.
Yes. I use the coughing technique as well. Have you ever used a coughing technique?
Yeah, I've done
the coughing technique.
Yeah.
It's just enough pressure to help the head come down without, because sometimes when you say, give a little push, there's no sort of, you can't measure a little push, can you? But,
and no one wants to do a little push because they just want it to be over.
Absolutely, yes. So I love a coughing technique.
Yeah, that's a good one. I like that. So yeah, it's that coughing, panting, blowing, and that's just to make that head come out a little bit slower. So that's something people probably hear. And then have we got any others before we move on? We've done positions, massage, oils.
Just having a scroll through.
Yeah, I had a water birth and sustained a 3B. Would I be able to have a water birth with my second baby? That's a really great question. And it's definitely something to have a discussion about. It's certainly not an absolute contraindication, but what it does mean is that when you're in the water, what we can't do is support your perineum or try to slow the birth of your baby's head, which may help reduce the extent of your trauma. We can't do that in the water. We can do that on dry land. That doesn't stop you labouring in the pool though. So it might be an option to labour in the pool and then hop out for the actual birth of your baby. So it's something to have a little chat about, I would say, before you present in labour, so you kind of can get your head around the plan, I suppose.
Definitely, absolutely. What else have we got? Can you use Vaseline? I don't see why not, but Vaseline can be quite greasy, so you might not get like a true, what's the words I'm looking for? It's quite slippery and greasy, Vaseline, so it might not be the same as using a specific oil or like a coconut oil. So give it a try, see if it works.
Yeah, it certainly won't do any harm. Yeah,
no harm.
Won't do any harm at all.
Yeah.
So, have we got
anything you wanted to add?
I suppose we should just mention the fancy technology that are on the market.
Yes.
So if you there's loads of different brands and loads of different names. The one I'm most familiar with is the Perineal brand.
Okay.
But I know there's others as well. Have you got any?
I think I get asked a lot about is it an Annie ball as well?
Yeah.
I think that's another one.
Yeah, I have heard of that one.
So Pip and I had a little chat about this before we did this live, and we were like, I think we need to mention these because we get asked about them a lot. But the truth is, there's just not much evidence to support their use, is there?
No, it's really contraindicated, and there's nothing that's kind of any good quality evidence. There's some small studies that suggest it might reduce episiotomy rate slightly, but again, it's really not very strong. So I think the evidence for perineal massage is probably slightly stronger. And more in its favour, and you don't have to fork out for some costly bit of technology.
Absolutely.
But obviously, it's entirely up to women, and some people use them and actually have really great success. So it's certainly something to consider. But I probably wouldn't recommend them based on the evidence that is around it all. Yeah,
absolutely, totally agree.
Just stick to a good bit of perineal massage if you want to go down that route instead.
Yeah, definitely. Absolutely.
Brilliant.
Well, I'm just looking. I don't think anyone's got any other questions.
No.
And I think we've covered pretty much all of that.
Hopefully we've covered a good amount and just got people talking about it, I suppose, and understanding their bodies a little bit more.
Yeah, definitely.
Brilliant. Oh, your sound just went there. No, it's fine.
Sorry. There we go.
You're back.
So I've dropped my phone and smashed my phone, so it's a little bit temperamental.
Bit hit and miss. Now, obviously, if anyone's got any further questions or wants to get in touch with either of us, they can message either of us, and we've both got loads of information on our walls as well. So have a little look at.
Absolutely. I shall save this as an IGTV and I will tag Pip at the bottom so that you can be directed to her page as well with all of her information, so that you can look back and watch this. If you've not been able to catch this right now, then you can watch the whole thing again.
Brilliant.
Okay.
Oh, thanks so much. Have a good evening.
So much. I'm glad we actually finally got together.
At last. All right. Have a good evening.
Much, Pip. Take care.
Bye.
See you soon.
See you later.
Bye.